In this video, I'm going to show you how to code a surgical case study using ICD-10-CM and CPT codes. This will be a great way for you to see how the codes work together with the report and get some practice on coding some real life scenarios. So let's get into it. But first, hi, if you're new here, I'm Victoria. I'm a medical coder, auditor, educator, and content creator. And on my channel, I provide tips, tricks, and tutorials to help you be successful in a medical coding career. If you haven't already, I highly encourage you to subscribe, hit that notification bell so you can get alerts when I post new episodes. Today we're going to be going over a knee procedure, and I am going to link in the description below the file, so if you want to look at the report yourself and see it a little bit easier than just watching me on the screen, you can have that to access and download. Now, if you're someone who's watching this because you just want to get a feel for what medical coding is, and you're thinking about this as a new career and you haven't started yet and you decide, yeah, I do want to do this, sign up for my medical coding masterclass. The masterclass tells you how to get started as a medical coder. Like, how do you go from someone who has no healthcare experience or maybe even a little healthcare experience to being someone who's job ready as a medical coder in as little as 6 months. It gives you that full roadmap. It takes away all the guesswork. So it gives you like the checklist of, okay, here's the certifications you should get. This is approximately how long it should take you, and then tells you what the best program is to meet all of the best requirements to become a medical coder. Definitely check the video description because I will have the link for that available. So let's get into this coding case. So here we have our operative report. We start out with patient name, provider name, the type of anesthesia given, the preoperative diagnoses, post-operative diagnoses. We code based off of the post-operative diagnoses because sometimes that diagnosis that we think we're going in for can change, especially based off of things like what happens when we may open up the patient, right? Or even things like pathology. So sometimes when we excise something from that patient, excision, we take it out and we send it to pathology. We finding out that a tumor that the patient had removed is cancerous. And if it just says, that the diagnosis there is tumor, and we don't know what type until we actually do the pathological examination and determine that final diagnosis, we don't want to code it incorrectly. We want to code based off of that final diagnoses. So it's either going to be that post-operative diagnoses, or if something like a specimen was sent to pathology, then we're going to code off of that final path diagnosis. So here you can see preoperative, we have torn medial meniscus of the left knee. Post-operative, we have the same thing, but also chondromalacia. Oftentimes the operative note will give you this procedure performed. Sometimes they'll just be a quick little thing. Sometimes they might be a bulleted list, depending on how involved of a procedure it was. This is probably your best jumping off point of what to code. Now, we don't code exclusively off of this. We have to verify that everything was described appropriately, that they did that full extent of the procedure, that nothing changed, nothing was omitted. So we have to read through the whole operative report, okay, make sure that everything was done. But this is a good jumping off point. This is a good clue as far as what might be in here, what actually happened to this patient while they were in the OR. Sometimes providers do just miss things in the documentation. I once had a hysterectomy report where it was a lap hyster, and the provider documented that they hooked the uterus, and then next thing you know, they were getting wheeled off to recovery. And I'm like, okay, you hooked it, but did you actually extract it? Obviously they did, but sometimes there's just so many moving parts that you forget to put certain things into the operative report. So when I was reviewing it with one of the coders, we noticed that it was, missing from the operative report description, that they didn't actually remove it. In that case, the provider can go back and provide a clarification via addenda and document that additional piece of information that was accidentally omitted. So here we have our procedure performed: arthroscopy of the left knee with partial medial meniscectomy, 3-compartment synovectomy, and chondroplasty. Here we have our operative findings. This patient had a radiographic examination in the AP, and lateral is positive for diffuse mild degenerative changes, positive for a tear in the medial meniscus as per the MRI. So there's nothing that looks different from what we have here in our post-operative diagnoses. So occasionally you might find an additional finding in here that could be an additional diagnosis, but usually it just matches up with the rest of the information. The provider isn't giving a diagnosis here. They're not saying that they have mild degenerative disease. They're just saying that there's changes. Arthroscopic findings included a tear in the posterior horn of the medial meniscus, grade 3 chondromalacia of the patellofemoral joint, medial femoral tibial joint, and lateral femoral tibial joint. And again, that chondromalacia is captured up here in our post-operative diagnoses. And then here we have the description of the procedure, where it's kind of like the difference between reading the summary of a book versus the actual book itself. It's that whole medical picture. It's that whole story of what happened, what did this provider do to this patient, and what was the outcome. So the description of the procedure: patient was taken to the surgical suite where supine on the operating table general anesthesia was administered. The left lower extremity was placed into a leg holder and then prepped and draped in the standard sterile fashion. The arthroscope and all arthroscopic instruments were introduced through standard portal. So this was an arthroscopic procedure, not an open procedure. Initial aspirate was positive for 60 cc's of normal appearing synovial fluid. Initial irrigant was positive for mild debris. Examination of the subpatellar pouch and lateral gutter revealed hyperemia and synovitis. Examination of the patellofemoral joint revealed a grade 3 articular cartilage changes to the lateral facet of the patella, median ridge, and femoral trochlea. So far he's not saying that he's done anything other than insert this arthroscope. This is all just kind of describing what he's seeing. Examination of the medial gutter revealed hyperemia and synovitis. So again, we're just going through, we're checking out what's going on through the scope. Now it looks like more examination description. Examination of the medial compartment revealed marked synovial proliferation anterior to the joint. There was a complex tear of the posterior horn of the medial meniscus. There were grade 3 articular cartilage changes to the medial femoral condyle and medial tibial plateau. Examination of the intercondylar notch revealed the anterior and posterior cruciate ligaments to be intact, both to vision and probing. Examination of the lateral compartment revealed marked synovial proliferation anterior to the joint with impingement. There were grade 3 articular cartilage changes to the lateral tibial plateau. No significant arterial cartilage pathology of the lateral femoral condyle. The lateral meniscus was intact, both to vision and probing the posterior, middle, and anterior 1/3. So still, we're just going through with the arthroscope, examining these different areas, checking out what's going on. Okay, but it looked like we had other procedures, right? So where are these? Where are we going here? With the aid of an up-bite basket, straight bite basket, and power shaver, here we go, now we go. A partial medial meniscectomy, so we're taking something out. We're taking out some of that meniscus. Partial meniscectomy. It was performed excising the complex tear of the posterior horn of the medial meniscus to a smooth, stable rim. With the aid of a power shaver, a 3-compartment synovectomy was performed. Excising a synovium noted to impinge the patellofemoral joint, medial femoral tibial joint, and lateral femoral tibial joint. With the aid of a power shaver, chondroplasty was performed. To the grade 3 articular cartilage changes noted in the patellofemoral joint, medial femoral tibial joint, and lateral femoral tibial joint. Okay, and then it looks like now they're cleaning the patient up. They did all their different surgical procedures on him. The knee was irrigated with copious amounts of normal saline and insufflated with 35 cc's of 0.5 marcaine. Arthroscope and all arthroscopic instruments were removed. Portals were closed and simple sutures of 3O ethelion. A compressed sterile dressing was applied. Patient tolerated the procedure well and returned to the recovery room in satisfactory condition. So let's take a look at these 2 pages together. So we have described here in our procedures performed, arthroscopy of the left knee. So down here is our arthroscopy. So that's the arthroscopy with the knee. So we're going to code out for that. Now that's probably going to bundle in with something else, but we'll double check. And then we have the partial medial meniscectomy, and that is the meniscectomy is, yep, partial medial meniscectomy, and they have the description of the procedure there, so we're going to code for that one. The 3-compartment synovectomy, we saw that one in here, we underlined that. We underlined it. And then finally we have the chondroplasty, and I believe, yep, here's our chondroplasty. And I didn't notice anything else that looked like a procedure that wasn't on this list. So we're going to code for these 4 procedures. Again, it looks like I have a hunch that some of these are going to bundle into each other. Now, I know some coders, especially if you're just learning or you're fairly new to coding, will look in the index for the different codes, but when you become more experienced, you'll likely do what I do, which is go to that section of the surgeries. So here's our musculoskeletal system, and we're not actually going to knee. You might think we're going to knee, but we're not. We're going to go at the very end here is where they have their endoscopy, arthroscopies. Now, when we get to this section, are we just going to start fishing around for codes? No, we're going to check some of our guidelines. Guidelines are gold. You need to know what you're doing before you just start picking at codes, right? So it says here, good reminder, general coding rule, surgical endoscopy or arthroscopy always includes a diagnostic endoscopy or arthroscopy. So what does that mean? Does that mean that we are going to code for this arthroscopy? Or is that going to be bundled in to our meniscectomies? That means it's going to be bundled in. So this code, we're not going to code, it's bundled all in there. So we'll start with our partial medial meniscectomy. Where are we here with the meniscectomy? So arthroscopy, temporomandibular joint diagnostic. So here's our knee procedures, arthroscopy, knee diagnostic, with or without synovial biopsy. What do we got here? This wasn't diagnostic, it was surgical. Arthroscopy knee surgical. Lateral release with removal of foreign body. Synovectomy limited, synovectomy major, debridement shaving with a chondroplasty. Abrasions, meniscectomy, medial or lateral, including meniscal shaving, including debridement, shaving of articular cartilage, chondroplasty, same or separate compartments when performed. So look at the difference between these two. It's almost identical, but can you tell where the difference is? The difference is this one says medial and lateral. This one says medial or lateral. And we did the medial, but we didn't do the lateral. So our code is going to be a 29881. So we can write that up there. 29881. And then we have our 3-compartment synovectomy. So that was also done through the arthroscope. So this is the same area. So here we have some synovectomy codes of the knee. We have synovectomy limited, synovectomy major, 2 or more compartments, and then debridement or shaving. Well, we had the 3 compartments, right? It was a 3-compartment synovectomy. So there's our 29876, and it says medial or lateral, and that's what we did. So here's our 29876. And then the chondroplasty is our last one. And right there, right below it is our chondroplasty. So our debridement shaving of articular cartilage, and then in parentheses it says chondroplasty. Now what does it say here? When performed with an arthroscopic meniscectomy, see 29880 or 29881. And we coded 29881. 29881, it says it includes that chondroplasty. So are we going to code that extra for the chondroplasty? We're not, because it's included in that 29881. So even though we had 4 codes listed here, or 4 procedures rather, we only got 2 codes out of it. Now, when we have 2 codes, what order do we put them in? Which goes first, which goes second? Well, they go in RVU order. So first off, let's check our Cci Validator, make sure that we don't have any CCI edits between these 2 codes that we have, 29876, validate. And we can see here, it kind of puts them in order for us, and you can see the RVU value. So 19.43 versus 16.12. I really like Find a Code. I find it very easy to use. It's a lot less busy. So if you're interested in a program like this where you can do code lookups and check CCI edits, look at lay descriptions of the different procedures, check my affiliate link in the description below. So this one's going to be our first listed procedure. This will be our second listed procedure. That's how I often mark them when I'm doing paper notations on operative reports. Now we have our diagnoses to consider. We have this torn medial meniscus of the left knee and chondromalacia. I didn't see anything else that was a definitive diagnosis in this operative report. It looks like there were some changes they notated. There was some sort of findings and things, but not definitive diagnoses. The provider diagnosed the patient with a certain particular condition. So I'm swapping out to my ICD-10 book. So our first diagnosis, torn medial meniscus, left knee. Don't know if the word torn is in there, but tear I think is. We always start in our alphabetic index in ICD-10-CM, always. That's the official guidelines. All right, so I looked up torn and it did say to look up tear. So we're under tear and then meniscus knee, current injury. We have meniscus, and then we have lateral and medial. It was a medial, but look, there's no default code here. They have the bucket handle, the complex, peripheral, and specified type not elsewhere classified. S8324. So let's see. Other tear of medial meniscus, current injury, other tear, right knee, left knee. So S83242. And if you look here, what does this icon mean? We need a seventh character. Do we have 7? 1, 2, 3, 4, 5, 6? Nope, we don't. So what's our seventh character going to be? So in this case, it's going to be either A initial, D subsequent, or S for sequela. Well, they're definitely not in their healing phase, so it's not a subsequent. So this would be A initial encounter. So S83242A. Now, if we look here at chondromalacia, it breaks down and there is a knee, there's a patella, there's all kinds of different regions for the chondromalacia, and there's also one for multiple sites, which if we kind of take a little bit of a deeper look into this operative report here, remember what we had here in our findings? So the findings say chondromalacia, right, of the patellofemoral joint, medial femoral tibial joint, and lateral femoral tibial joint. So that's 3 different areas. So I think we're good with using this area of multiple sites, the M94.29. Let's double check that in our tabular list. So here it is, chondromalacia, multiple sites. No additional digits, so we're good to go there. So for our CPT codes, we have 29876 and 29881, and then our diagnoses S83, I know my S's look like 5s, 242A and M9429. So there you have it, a simple guide to coding a surgical case. They do seem complicated at first, but when you follow the different steps and get used to it, it becomes a lot easier. And if you want to learn more about medical coding, definitely sign up for my medical coding masterclass to learn how to get into this amazing field. I will definitely see you guys in the next video. And until then, just keep on coding on.